Hi, I'm Kyle Harrison. This is the unstable tachycardia module. So I'm going to go over the treatment of unstable tachycardia. So let's begin. So let's define tachycardia. So basically a tachycardia is any heart rate greater than 100. Now how do you have unstable tachycardia? Well, it needs to have decreased perfusion. So you basically need to have a heart rate greater than 100, and there needs to be decreased perfusion that's related to the tachycardia. And that's important because to be unstable tachycardia, you need to be operating under the assumption that the heart rate is the reason the patient's having poor perfusion. That if you identify the patient that is having poor perfusion and has an elevated heart rate greater than 100, that may actually be sinus, and the poor perfusion could be a myriad of causes such as hypotension, um, uh, fever, sears, etc. So you need to first make the assumption that the rate is the cause for the poor perfusion. So that means that usually the rate needs to be greater than 150 beats per minute. Most people will tolerate, with an adequate perfusion, a heart rate less than 150. There are some subset of patients who have such poor physiologic reserve or have, for example, aortic stenosis, where they have a fixed lesion, that maybe they won't tolerate a rate that's greater than 120 or so. But in general, for a patient to be symptomatic, they usually have to have a heart rate greater than 150. So tachydysrhythmias, so dysrhythmic causes that result in poor perfusion, are usually a greater rate than 150. So what are the signs of instability? So it could be hypotension. You could have acutely altered mental status, which could be confusion, stupor, syncope, or actually unconsciousness. You can have signs of shock. You could have ischemic chest discomfort. The patient reports that they're having chest pain. They can be cool and clammy. They may have acute heart failure with shortness of breath and pulmonary edema. What are the symptoms? Obviously chest pain, dizziness, and shortness of breath. These are the ones that the patient is going to report. Let me go back to the signs. So ischemic chest discomfort would be, you might see EKG changes for that. Hypoxemia might be the result of the acute heart failure. These are the signs, and then the symptoms are what the patient reports. So dizziness, shortness of breath, and chest pain. So any of these symptoms or signs that are associated with a rapid heart rate prompt you to place the patient in the unstable category for your treatment algorithms. So what are the common tachydysrhythmias? So atrial fibrillation is probably the most common. Usually doesn't get that fast, but it can. Atrial flutter, once again, usually even a little bit slower than atrial fibrillation because of the variable conduction delay, but if it's a one-to-one conduction, you can get pretty fast. Reentrant supraventricular tachycardias, or SVTs, these often get faster than 150. Monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, and then wide complex tachycardia. And what I mean by wide complex is that the QRS duration is greater than 0.12 seconds. So these are aberrantly conducted. If it's a VT, it's VT, but you can actually have an SVT that's aberrantly conducted, and you have a conduction delay, so it looks like VT, even though the foci of the inciting rhythm may actually be a supraventricular rhythm, but it may appear to look ventricular. Once again, VT without a pulse should be treated as a ventricular fibrillation with CPR and emergent defibrillation. So these are all tachydysrhythmias with a pulse. So the first thing you're going to do is establish the airway, make sure the patient has an airway, make sure they have 100% oxygen. Assess circulation. Clearly, if they have no pulse, then you need to start chest compressions and switch to your other algorithm. All patients that are tachy need supplemental oxygen until you come to the cause. Will buy maybe a little time and hopefully improve your oxygen delivery to the periphery. Patients should be on continuous monitor. Sometimes it's prudent to go ahead and bring in the crash cart, A, because you may need it, and B, it's a cardiac monitor that you can have there at the bedside. if your patient's on telly and you want to actually see what's happening in real time, or the patient's not even on a monitor, that may be your most effective way to get a patient on a monitor quickly. You can establish IV access, and then if time, you can perform a 12-lead EKG, which would allow you to get a little more diagnostic information than you could just off the rhythm analysis off the cardiac monitor. So once you've done that, it's important to determine at this point, is the patient stable or unstable? And is this a wide or narrow complex? Because this is going to play into how you treat the patient. So let's start with unstable first. So the patient, you hook them up, you identify that they're unstable, either they're having ST changes, they're reporting chest pain, they're dizzy, they're hypotensive, they're just not tolerating the rapid rate. You need to immediately connect the defibrillator using the quick combo pads. You can't use the paddles to do a synced cardioversion, so you need to use the pads. Go ahead and hook those up. You can do anterior, posterior, or anterior lateral, depending on how you want to place them. Then you want to turn on the defibrillator feature, and once that comes on, then it's important to identify where the synced button is, because you need to sync this cardioversion to the patient's R wave. Before you do it, you want to make sure you have at least basic emergency equipment available in case the patient decompensates further. As the patient becomes more hypotensive, their brainstem may become hyperperfused, they may become apneic, so you need to be able to support their respirations. You need to have the ability to shock the patient if they convert into ventricular fibrillation or decompensate into ventricular fibrillation while you're assembling your equipment. So you need to have resuscitation drugs available. And if you feel like you don't have enough hands, then it would be appropriate to call a code, even though the patient's not pulseless. The patient is unstable and may progress to a pulseless position, so you need to anticipate and plan for that. So if you're ever uncertain, need help, go ahead and call the code. It's okay even if they have a pulse to call a code. And then you want to consider sedation, because what you're going to have to do is you're going to have to do this emergent cardioversion. So if at all possible, you sedate the patient, but don't withhold cardioversion on an unstable patient if you're not able to get adequate sedation. And you may not be able to give adequate sedation because the patient may be hypotensive or so unstable at that moment. If you do need to give something, you can try a little fentanyl for analgesia. You might try a little midazolam for anxiolysis and amnesia. But once again, you need to be careful, because that unstable patient may decompensate when you sedate them. If you have emergent access to an anesthesiologist, then they may be able to assist with the monitoring and sedation for this procedure. So connect to the monitor. It's now important to charge the defibrillator. You need to pick the joules for which you feel you're going to be successful, but don't use too much energy. So this is some guidelines. So a narrow complex regular, so likely an SVT, you can usually use lower energy, so 50 to 100 joules may be appropriate. As it becomes narrow complex and irregular, so talking about atrial fib, atrial flutter, you're going to have to increase the joules, so you may have to go up to 200 joules. Once again, these are all biphasic energy descriptors. Wide complex regular, once again, you can drop the joules. And then wide complex irregular, this is a polymorphic VT or VT, and so you just need to cardiovert it the maximum, which is 200 joules, and you need to do it unsynced, because if it's irregular, it may have trouble locking in on an R wave, and the patient's at risk for decompensating into a pulseless condition in this predicament, so you don't want to delay for that. All others, you should take the time and sync the defibrillator, and I'll show you how to do that at least on the one defibrillator that we have for demonstration purposes. Once you've confirmed that you have capture with the sync triangle or mark, however the defibrillator does this, you should be familiar with your own institution's defibrillators. Once you've confirmed you've got capture, sync button is hit, then you need to clear the team, and then you need to charge up the defibrillator, and then you hold the shock button down, and you may have to hold it for a few seconds, because it's going to wait until it gets an R wave. It's not a binary, just you hit it and it shocks. You have to continue to hit the button until the energy is delivered, at which time energy may be delivered depending on how rapid the rate is, and if it can get a sync on the R wave, it may be quick or maybe a few seconds. So make sure you hold it down until you see the energy delivered. This just shows a picture of a defibrillator pacemaker that we're using for demonstrative purposes. You can see the defib, which is it's the same. Defibrillation, cardioversion are the same. It's sometimes people will say defibrillation if you don't sync it. They'll say cardioversion for synced, but it's basically electrical energy to change a rhythm. So you turn it on to the defibrillator setting. You hit the sync button. You can see there on the row of buttons on the lower right, the sync button on, and then you see the little arrows that are now locking in on the R wave. So this is synced and ready to go. So should mention that going back, if you are unsuccessful, then you may need to increase the joules and repeat it. If the patient's still unstable, you need to keep pushing ahead with attempted cardioversion. If they're in atrial fibrillation, they may not be able to be cardioverted out of it, so then you may need expert consultation to try and give additional medications to try and chemically convert them. But usually an unstable patient, they're able to be converted with 1 or 2 cardioversions. That is, once again, bring up another good point, that after you've used and done your first shock, all defibrillators switch out of synced mode. So you need to resync it before you attempt a second defibrillation. The reason for that, it's considered a safety feature, so that if the patient gets shocked into a lethal rhythm, into ventricular fibrillation, then you can immediately defibrillate them. So they don't want it on synced because you will never capture a VFib. There's no R wave, so it can't capture. So if you ever defibrillate someone into VFib, just simply defibrillate them unsynchronized. If you defibrillate them and they don't convert, simply, and they're still in an SVT or an atrial fib or something, then simply resync and increase the energy. So let's talk about stable tachycardia. Now, stable tachycardia, it's important to determine if it's wide or narrow. The reason for that is if they're stable and you have time, you may want to wait and talk to or consult a cardiologist for more information. But if at any moment the patient develops instability, you may need to switch to the unstable pathway and do an urgent or emergent cardioversion. One other thing to note about treatment, once you decided if they're stable or unstable, you then need to decide whether or not it's a wide or narrow complex. So no matter what, if they're unstable, wide or narrow, you're going to cardiovert. Unstable is always immediate cardioversion. But if they're stable, then you need to decide, is it narrow or wide, because that's going to change how you proceed down your treatment algorithm. So let's first talk about wide complex. So once again, QRS complex greater than 0.12 seconds. A patient is stable, so you have time to do a further assessment of the rhythm. You may need to do a 12 lead to try and determine this, but you want to know, is this polymorphic or monomorphic? And what I mean by that is when you look at the appearance of the tachycardic, the wide QRS complex, is it variability between beat to beat, where the amplitude shifts, or is it that every beat looks the same? So every beat looking the same has been considered monomorphic, meaning kind of one appearance. If each beat looks different, then that would be polymorphic. As we mentioned before, a wide complex may be ventricular, or a wide complex may be a supraventricular rhythm that has an aberrantly conducted pathway. So that's important to note, but if you're ever uncertain, it's more important to assume that it's the more dangerous rhythm, which is ventricular tachycardia, and treat accordingly. Once again, if the patient's pulseless, you're going to just shock them. If the patient has a pulse and is stable, even though it looks to appear ventricular tachycardia, you can take time and treat with drugs first, as long as they're stable. So, first-line drug for unstable tachycardias is adenosine. Now, adenosine is used for regular and monomorphic wide complex tachycardias. So, you've got a regular monomorphic regular tachycardia. It's either VT with a pulse, or more likely it's an aberrantly conducted SVT, adenosine is appropriate to give because you have about a 90% chance of converting these patients if you use that as your first-line agent. Highly polymorphic, so once again, the QRS complex looks different each beat. This is more likely torsades, and this is often associated with metabolic derangements, often harder to treat pharmacologically. So the treatment for this would be you can give magnesium sulfate, important to treat the underlying metabolic or electoral abnormalities. If the patient develops instability with this, then you're going to do the unsynced cardioversion. Some of these patients need rapid overdrive pacing, which is really out of the scope of the course. So those are when you need to get expert consultation for these patients. So get help. Be ready to do an emergent cardioversion if they become unstable prior to help arriving. But you basically have polymorphic, wide complex. Go ahead and wait until you get some help. Narrow complex, you can attempt adenosine while you're waiting for your expert consultation to arrive. Monomorphic irregular. So before we were talking about monomorphic regular, now we're talking about monomorphic irregular. So they appear similar, but they're irregular. This is probably aberrantly conducted atrial fibrillation because the irregularity is always, almost any irregular rhythm is almost always an atrial fibrillation. It may be aberrantly conducted, but it's important to treat this patient. Monomorphic irregular as an aberrantly conducted atrial fibrillation or pre-excited atrial fibrillation. So there are several forms of pre-excited reentrant rhythms. Wolff, Parkinson, White WPW is the most common. So a reentrant atrial fibrillation in a WPW patient may look white complex. So for these, you want to try and rate control the patient with either a beta blocker or a calcium channel blocker. But you're going to avoid beta blocker or calcium channel blocker in these pre-excited atrial fibrillation patients. So patients with WPW, got to be cautious about using nodal blocking agents because you may only block the nodal pathway and not the reentrant pathway, and you actually speed them up. They can actually even end up in ventricular flutter. So you always have to be prepared for emergent defibrillation if you're using pharmacologic interventions on a patient with WPW. You may just need to go straight to a synced cardioversion. Can use adenosine, but once again, you got to be careful because you may flip the patient to a more rapid rhythm. So the pre-excited patients, the reentrant pathway patients, you probably need some expert consultation. But no, if they're really unstable, you just have to do the cardioversion. So no matter what, that's always your go-to. So instability always results in synced cardioversion. You can do that, and you should be able to do that if the patient's unstable. Things you can do pharmacologically for a wide complex stable tachycardia in addition to adenosine. So once again, you're not sure, is this a ventricular tachycardia with a pulse? Is this aberrantly conducted atrial tachycardia or atrial fibrillation? The nice thing is you can use amiodarone, and it's going to work for both ventricular and atrial dysrhythmia. So it's a little different than when you're given the code dose. If you remember, the code dose was 300 milligrams. For this, because the patient has a pulse, it's important that you reduce the dose to 150 milligrams, and you need to give it slower. So you need to give this over 10 minutes. You do not push this drug. The reason for this is that it's going to cause hypotension, and this patient probably are not going to tolerate even the least amount of hypotension because they're already pretty tachycardic, and their perfusion may already be limited. So 150 milligrams IV over 10 minutes, and you can follow that by an infusion, which is 1 milligram per minute over 6 hours. If you need to repeat the dose, you can repeat it. So a total of 300 if you need to. So 150 over 10. If that fails to convert or rate control, reload with another 150 and then do the infusion over 6 hours. Two other agents you can use, procainamide and sotalol. Once again, these are acceptable for treating wide complex stable tachycardias, but you may need to consult a cardiologist for dosing because you may not be familiar with this medication are these medications. So now let's move away from the wide complex to the narrow complex. So reviewing overall, we've talked about unstable, both wide and narrow cardioversion. Stable wide, adenosine or amiodarone, always ready to defibrillate if the patient becomes unstable. Now we're talking about narrow complex stable tachycardias. So these are the SVTs, so the rapid rate but narrow complex, either rapid AFib or supraventricular tachycardia. Now it's important that you rule out that this isn't sinus tach, because sinus tachycardia is a tachycardia, but then you're not going to treat sinus tach the same way that you're going to treat a tachydysrhythmia. Sinus tach is a compensatory mechanism to maintain perfusion, so you don't want to treat that. You want to figure out what the cause of the sinus tach is and treat that. If you just try and rate control or slow someone down in sinus tach, you're going to likely end up with a very hypertensive patient, because the reason they're tachycardic is that they're driving their heart rate up to maintain adequate perfusion. So look for the underlying cause and treat that if it's sinus tach. Once again, most patients are not going to have a heart rate greater than 150 if they're in sinus tachycardia. It's going to be in the one, and the older you are, the less likely to have a rapid rate with sinus tach. So a young healthy person may be able to get up to 140s, maybe 150s, but an elderly patient is not likely to get 150 at sinus. It's probably a dysrhythmia. So things you can do in a narrow complex stable tachycardia. So the fastest and successful in about 20 to 30% of the time will be vagal maneuvers. So what are vagal maneuvers? So the Valsalva, where you're going to have them take a deep breath in and then bear down in a closed glottis. So basically hold their breath and bear down. So this is a Valsalva maneuver. This can be successful and causes a vagal stimulus, which may terminate the dysrhythmia. You can do carotid sinus massage by carotid massaging the carotid sinuses in the neck. Cautious with carotid sinus in patients that have peripheral vascular disease. So if they have carotid disease, you will want to avoid rubbing the carotid sinus. You may dislodge a plaque or cause a cerebral vascular accident, a CVA. So cautious in elderly and patients with peripheral vascular disease. But young healthy people, you can do Valsalva, you can do carotid sinus. If not, you can move to adenosine. Once again, going to be successful in probably about 90% of the time, so it's a very successful drug. What it does is it creates a very high degree AV block, basically terminates all conduction through the AV node. These patients may even be briefly asystolic for a few seconds. Allows the normal conduction pathway to resume. So it's almost like kind of a, if you will, an alt control delete to the conduction system that then lets the natural pathways kick back in. Things to know about adenosine. It's rapidly metabolized. It's probably the most rapidly metabolized drug that is in the system that we have available to us. So you've got to give a push and inject saline to flush it in rapidly. So starting dose is 6 milligrams peripherally, and you rapidly flush it in so that you get the full drug effect into the heart as quickly as possible. If that fails to terminate the rhythm, you'll always see a result. If you don't see a slowing, then the patient didn't receive the drug. You'll always see something. It may not be enough, or it may not be enough to reset, and the patient may speed back up, but you'll always see something. So if you don't see anything, you should worry that you didn't actually give the drug. But you give the drug, you see slowing, but then the patient kicks back into a rapid rhythm, then you can repeat it. The next dose would be 12 milligrams, so you double the dose, and then once again rapidly push that drug in. Consider reducing the dose to 3 milligrams if you're using central access, or if the patient is status post heart transplant. There have been some case reports of patient with prolonged asystole when you use the higher doses with central access or in a heart transplant, denervated heart. Can cause bronchospasm, so you have to decide the risk-benefit ratio in asthmatic patients. Will it convert atrial fibrillation or atrial flutter? No, but if you're uncertain, it may slow it down so you can see the flutter or fib waves. If it's SVT, like I said, you have a good chance of converting. So it can be used diagnostically, can be used obviously therapeutically, and it is a good and an effective drug as long as you understand how it works and how you can need to flush it rapidly. So refractory tachycardias, either you've done the adenosine in their back or you've shocked them in their back, that requires urgent expert consultation for further management. If their patients are not responding to the usual treatments, they're going to need advanced pharmacological intervention, maybe override pacing if it's torsades or something. So that's going to require expert consultation. So get the help in. That's beyond the scope of this course. Finally, let's talk about narrow complex stable tachycardia that is irregular. So these are the atrial fibrillation flutter patients. These are the ones that you want to rate control because adenosine is not going to convert them. They're stable, so they don't need cardioversion. You just need to slow them down. So rate controlling them with a beta blocker, such as esmolol, is short-acting, but it may break them, or metoprolol, atenolol, or using a calcium channel blocker such as distill-tiazim may slow the conduction through the AV node. It's not going to convert them, but it may slow them down so that they're more stable at a slower rate. Amiodarone will be rate controlling, and in some set of patients will chemically cardiovert them. So you get 2 for 1. It may not convert them, but it may slow them down, or maybe it will even convert them. Once again, the dose is 150 milligrams over 10 minutes, followed by your infusion of 1 milligram per minute over 6 hours. So as I wrap up, I just want to briefly mention again, any tachycardia that is unstable, it's immediate synced cardioversion. Any stable tachycardia, you need to decide, is it wide or narrow complex? If it's wide complex, regular, you can try adenosine. If it's wide complex, irregular, you're going to use amiodarone. Narrow complex, regular, you're going to use adenosine. Narrow complex, irregular, you're going to use a calcium or channel or beta blocker or amiodarone. So quick overview of stable and unstable tachydysrhythmias. Once again, as always, you should refer to the AHA 2010 guidelines and the Advanced Cardiac Life Support Manual for a more extensive discussion of these topics. But this should give a nice overview, I hope. Thank you.